Good afternoon, everyone, and thank you so much for being with us today. Before I begin, I want to acknowledge two of our department's great health leaders who are here with me today. The head of our Medicare and Medicaid Innovation Center, Dr. Rick Gilfillan, who is here on the stage, and our Deputy Medicare Administrator, John Blum, who is also here on the stage. And I especially want to recognize and thank the health leaders who traveled here from around the country for this very important announcement. Not only thank you for being here today, but thank you for the critical work you do each and every day. Today we're taking an historic step to improve healthcare in America. Under the Affordable Care Act, 32 leading health systems and physicians organizations have been selected to test a new model of care in which they will transform their practices to emphasize prevention, improve care coordination, cut waste, and put a greater focus on patients' needs. These pioneer accountable care organizations will improve care for over 860,000 Medicare beneficiaries, are estimated to save the Medicare Trust Fund up to $1.1 billion over the next 5 years, and most importantly, become role models for the rest of the country as we move toward a future in which all Americans get better care. Today's announcement comes at a time when there's an unprecedented understanding that we need to improve health care. Despite having the world's best doctors and nurses, the most advanced technology, and the finest hospitals in the world, America continues to live sicker and die sooner than our peers around the world. Each year, healthcare costs consume a greater share of our paychecks, corporate balance sheets, and local, state, and federal budgets, with no sign of slowing down on their own. But fortunately, this is also a time of unprecedented understanding about how to make improvement happen. In the last 2.5 years, I have had the privilege of visiting some of the leading health systems around the country that are already hard at work changing the way they deliver care to prevent illness, to help patients manage their chronic condition, to improve care transitions, and to reduce medical errors. These systems have healthier and happier patients and happier healthcare providers. And perhaps most important of all, many of them are finding that doing care the right way can actually bring down costs. At a time when there are those in Washington who say we have no choice but to make some of the most dramatic cuts to our healthcare programs ever proposed, the leading health systems across America are showing that there is a better path forward. But in order to widen that path so it can include all patients and all providers, we need to get rid of the significant obstacles standing in the way of improvement. And that's really what today's announcement is all about. The Pioneer Accountable Care Program is one of the several options created by the Affordable Care Act to help healthcare providers who want to improve care. For the first 2 years, it works like a supercharged version of the Medicare Shared Savings Program. In that program, if the pioneers can lower costs for their patients on Medicare by improving care, for example, following up on discharged patients so they don't end up back in the hospital, then the pioneers get a share of the savings. For pioneer ACOs, it's even a higher percentage of the savings. Now today, too many hospitals actually lose resources when they help prevent unnecessary readmissions. After all, a hospital with empty beds is one that's not making any money. In the shared savings models, these incentives are flipped. Suddenly, keeping your patients healthy and out of the hospital becomes a sustainable business model. And pioneer ACOs will take this model even further in 2 ways. First, if they're successful, they have the option in the 3rd year of moving toward a new payment system where they no longer get paid based only on how many procedures they do, but on how well their patients do. Second, they've committed to making similar payment arrangements with other private and public payers besides Medicare. In other words, they're committed to focusing their entire practice around these new goals. Now, this announcement wouldn't be possible without the hard work of our staff here at the department, our partners throughout the federal government, and especially the 32 pioneer ACOs represented here today. It's not easy to change ways of delivering care that have been in place for decades, but these pioneer health organizations have agreed to take on the challenges because they believe that if they deliver better care, their organizations will ultimately thrive. So I want to take another moment to say to each of the leaders here today, thank you. Thank you for stepping up to show us what the future of healthcare will look like. But the most important question we need to ask any of our healthcare system is, what does it mean for the patients? First, it's important to note what won't change. This won't limit consumer choices at all. Even if your doctor is part of an ACO, you can still choose any provider you want, and you'll still have all the guaranteed Medicare benefits. But here's what could change. Your doctor may be able to spend more time with you because she won't have to rush off 10 minutes after to do another visit. She could have a little more time to talk to all the specialists so that you won't have to fill out the same form over and over every time you have an appointment. She may be able to work with you to help you manage your conditions and stay healthier without worrying about whether she is going to have to bill for that or not. Now, we hope that other physician organizations and hospitals will follow in the footsteps of the pioneer ACOs, but there's not one single path to better care. That's why through the Affordable Care Act and other efforts, we're giving providers a menu of options for improving care. There's shared savings models for hospitals that aren't quite ready for the Pioneer ACO program. We've started a partnership for patients that has already signed up more than 3,000 hospitals and numerous employers and other partners to reduce medical errors and unnecessary readmission. And we've recently issued a healthcare innovation challenge, asking innovators around the country to come to us with their best ideas for lowering costs by improving care. We'll pick the top ideas, give them money to test them, and if they work, we'll be able to implement them on a national scale so patients and providers won't have to wait to reap the benefits. This is an incredible moment. The Affordable Care Act has given us a platform, a huge opportunity to improve care, and healthcare providers are moving forward to seize that opportunity like never before. But among all these innovators, pioneer ACOs have a very special role. They won't just improve care for their patients, they'll also blaze a trail toward better care for all Americans. And I can't wait to see what lies ahead. Again, thank you all for being here with us today, and now I'd like to turn it over to Dr. Gilfillan. Rick?
Thank you very much, Madam Secretary. It's a historic day, and I thank you for the leadership and support you've provided in getting us to this day. I also want to thank the hardworking and dedicated Pioneer ACO team at the Innovation Center, led by Rich Barron and Pauline Lappin from our Seamless Care Group, and most directly by the brilliant and terribly and remarkably effective leader, Dr. Mai Pham, for getting us here. I must say that every Pioneer leader I've spoken with have gone out of their way to remark upon the customer service ethic that has been demonstrated by Mai's team. They've set a new standard for customer service, for being a trustworthy partner that we will all work hard to live up to. I also want to thank John Blum, my colleague here at CMS and the director of the Center for Medicare, whose team has continued to work very hard and long hours to implement the Medicare Shared Savings Program. I hope the level of coordination and teamwork that has characterized the work between John's team and the Pioneer team is evident to everyone who's interested in ACOs. I want to also thank our federal family, partners here at HHS and beyond who have worked tirelessly to support this work, and as several folks have said to me today, this has been warp speed for you all and for us, and we recognize that and appreciate your efforts. Here in particular, we want to single out the work of our actuarial, legal, and information systems teams at CMS, and also our colleagues at the Inspector General's Office and the Department of Justice who helped us get through the waivers associated with this program. Finally, I want to also thank the 32 pioneers, your executives, your boards, your clinical staff for demonstrating the unflappable commitment to leading us into that future healthcare system that produces better health, better care, and is sustainable. This is a partnership that started well before today. looked out in the audience today and see people who have been coming here to CMS, to HHS, repeatedly over the last 2 years, encouraging the Innovation Center and CMS to reach out and build this relationship, and we appreciate your persistence and engagement with us. When I was thinking about how we got here today, I was struck by the fortuitous circumstances that have come together to create this announcement. As many of you know, the Affordable Care Act created many new opportunities for CMS to partner with doctors, nurses, and hospitals to create a better healthcare system. One of those opportunities is the Center for Medicare and Medicaid Innovation. And the Innovation Center is tasked with testing innovative payment and care delivery models to find new ways to accomplish these better outcomes I just mentioned. The Center is giving us a great opportunity to take advantage of one of our nation's most exciting resources, you and others like you who are doing the innovative work around the country trying to find ways to improve the quality of care for our beneficiaries. Every day, we at CMS and HHS are incorporating lessons from this work and turning your ingenuity into innovative models that will shape care delivery. When we first began our work only 1 year ago, we knew we wanted to find a way to partner and learn from some of the extraordinary organizations around the country, like you all, who are transforming their business model and their care models every day. It was from that idea, from that kernel, from our exposure to you, that we developed the ACO model, the Pioneer ACO model. Now, the 32 Pioneer ACOs announced today represent an incredibly diverse and advanced group of organizations that were selected after a fairly rigorous process. The final pioneers represent 18 states from the Southwest to the Upper Midwest to the Northeast. They come from rural, urban, and suburban communities. They represent a broad diversity of backgrounds, some larger IPAs, some integrated systems, some physician group practice-based, and some hospital-based. They bring a richness in their approaches to improving care, and they represent some of the best of what our country has to offer in delivering high-quality, patient-centered health care. As the Secretary said, under the Pioneer model, these organizations will be rewarded for delivering high-quality care and reducing costs to Medicare. But we also understand that these organizations are taking on financial risk and will be sharing the responsibility for Medicare costs. We are indeed becoming partners, sharing responsibilities, opportunities, and most importantly, commitment to better care for patients. The model allows us to use a new payment arrangement that moves the entire organization away from fee-for-service payment to new approaches that reward the delivery of cost-effective, high-quality care. It gives you the freedom to be more innovative in the way they design and you design care for the patients you serve. They can show the country what's possible in driving towards better health at reduced costs through improvement for the entire Medicare population. Additionally, all of the Pioneer ACOs have agreed to ensure that over half of their revenues will come from similar payment arrangements with commercial and other public payers. These organizations are not just agreeing to new working agreements and arrangements with CMS, they are agreeing to be part of a larger movement towards new models of care for all Americans. Payments will not be the only thing changing under the Pioneer ACO model. At CMS, we are changing how we think of the relationship between provider and payer. We have hardwired into the Pioneer model meaningful and ongoing engagement with patients through monitoring, Pioneer governance structures, communications, and programs to track the patient's experience of care and plan shared learning activities. We expect that the model will continue to evolve and improve over time as we all engage together to find additional ways to support the work of improving care. As the Secretary said, the model is only one piece of the larger effort at CMS to identify, test, and spread new ways to deliver and pay for care. We've created a wide variety of organizations to partner with us in this endeavor, whether through our bundled payment for care program, which seeks to pay for care as an episode rather than a fragment, or our investment in primary care transformation and revitalization. There are opportunities for many types of organizations and providers. And of course, we recently released the HealthCare Innovation Challenge, asking providers around the country to come to us with their best ideas for improving outcomes and lowering costs. Some may rush to label the Pioneer ACO model or other work at CMS as simple demonstrations. We think of it as much more than that. We think of it as an opportunity to begin this new partnership. We look forward to beginning that work and building a better health care system for generations to come. We know our country needs a better health care system that is sustainable, producing better health and better care for all Americans. Transforming health care means asking leaders like you all today to change the basic clinical and business models that have made you and your organization successful in the past. You know, and we know, that the current system is not sustainable. You know that we have to change, and you also know, as I've heard today from you, that change is difficult. It would be easy to hold back. These pioneers are not holding back. They are leaning into the challenge of moving into the future. In doing so, they are demonstrating that the great American capacity for innovative energy and entrepreneurial endeavor can be released to address a critical social and human need, improving health care so that we can make the best care available to all Americans. You are optimists who believe that we can and will do better. You are an inspiration for us and will be, we believe, for other healthcare leaders. Thank you very much for being here. I'm honored now to turn the program over to one of your inspirational leaders, Dr. Nancy Boner, an internist and chief medical officer at Monarch Healthcare System, to further explain what today's announcement will mean for clinicians and patients.
Thank you. Good afternoon, everyone. On behalf of Monarch Healthcare and all those selected to be Pioneer ACOs, we are extremely honored to have been selected for this important and historic initiative. We look forward to dedicating our energies, talents, and resources to help create a more effective care delivery system. This will result in higher quality care, better experience for our patients, and reduce growth in Medicare spending. We will achieve these goals by providing care coordination support for our patients and their physicians where and when they need it. The Pioneer ACO will work to improve health within our communities with regards to wellness through enhanced preventative care programs, and will offer personalized assistance to patients and their families after and before acute illnesses. For people with chronic diseases, we are committed to forging stronger doctor-patient relationships that ensure patients have the support and skills they need to effectively manage their conditions and maintain independent living. I'd like to share a couple of examples specifically of how Monarch Healthcare coordinates care for its patients, examples that I believe reflect the kinds of progressive activities occurring within other Pioneer ACOs. The first example relates to patient safety and medication management. Our pharmacist, Gigi, personally engages patients who rely upon more than 6 medications and who may have been recently hospitalized. Just this month, Gigi contacted one of our patients who had just been started on a higher-risk blood thinning medication. This was in addition to 20 other prescriptions, yes, 20, prescribed by various physicians who were providing care for the patient. Through her monitoring of this potentially dangerous situation, she was able to educate the patient so that he could take his medication safely and actually streamline his medication regimen. Patients have been pleasantly surprised when they hear from Gigi on the phone. They have told her how grateful they are that they have an expert, a real person, who is watching out for them. The second example demonstrates how Monarch Healthcare helps our patients navigate through the complex healthcare system. We help them receive timely and appropriate care. In other words, we want to ensure they receive the right care at the right time. One of the ways we do this is through our nurse care managers, who are dedicated to a small number of patients with one or more chronic diseases. Beginning about 11 months ago, one of our nurses named Starb has helped an elderly diabetic patient successfully get through multiple surgeries for a foot amputation involving a wound infection and specialized physical therapy. She would personally call him on a regular basis, and at peaks of his acuity, she would call him twice a week. She would answer his questions, she would help him navigate and understand what the next step in his care plan was and make sure that he kept his appointments. This week, this gentleman is excited to meet Star for the first time face-to-face. He's coming to our office, he's bringing her some homemade food, and he wants to thank her, and he wants to show her how he can walk on his prosthetic leg. This kind of coordination that happens in between physician appointments are among the most effective tools in preventing unwanted emergency room visits and hospitalizations, and creating a better experience for our patients. I only wish my own father could have had access to the same sorts of services before he passed away this year at 86. I am certain that each and every Pioneer organization here today can share its own success stories just like these. Our challenge and our goal is to successfully engage patients and all who take care of them to work together to help them create for them a seamless path through this fragmented healthcare delivery system. Like the early American pioneers Lewis and Clark, we are prepared for this journey but cannot know now every circumstance we will face. To achieve these goals, pioneer ACOs will need to be innovative, nimble, and perseverant. We can accelerate our individual and collective success by purposefully sharing our experiences in a full spirit of collaboration. By definition, pioneers are those who are willing to stand up, embrace challenges, and are committed to making a positive difference in the world. I think I can speak on behalf of all the pioneer ACOs when I say we are honored and proud to have been chosen for this historic endeavor and look forward to working with the Innovation Center. We will put forth our utmost effort to ensure this program succeeds for our patients, our dedicated doctors, and the communities we serve, but most importantly, on behalf of our great nation. Thank you.
With that, we'd be happy to answer some questions if you have some questions for us. Rick is here and John Blum may be called in. I told Dr. Boner that she gets the tough questions. We'll take the easy ones. Yes, sir.
Could you share some detail about how the financial arrangements are going to work out for these organizations and how that might differ from the folks coming in MSSP?
Do you want
Sure.
to take that, Rick?
Yes. We've developed a variety of models. They start with shared savings typically, with some downside risk, if you will, in the first year. The details are available on our website. Suffice it to say that I guess the most important elements are broader range of opportunity, and in the third year, the opportunity to transition to a sort of capitated type payment, which is not part of the shared savings program.
Yes, sir.
Hi there. Could you talk about the number of applicants that were denied and what differentiated those that were chosen from those that were not?
Yeah. Well, I would say along the way, we received a total of 80 originally, and through
Well,
a
it
process.
started with 160 letters of intent.
And yes, we did have, started with 160, 80 applications, gradually through a process of panels review of those applications, interviews. We kind of found our way to the 32 that you see here today and that are listed on the website and in the materials. So there was, I wouldn't say people were denied, I would say we went through a process that identified folks who really felt strongly about continuing the participation and some who felt that there might be other avenues to pursue that could get them, that were a better fit for where they were in their, at their stage of development.
Yes.
The 1.1 billion, I guess, is the savings target over 5 years. How much of that would go back to the hospitals that are participating in the program?
Yeah, the savings, that's the net savings that comes back to the program.
That's all that.
Yes.
Right. That's the
Yes,
Medicare.
that's the Medicare
savings.
portion of that. It varies depending on the particular model, and it's harder to project given the fact that the distribution of dollars will vary by the different ACOs that are out there. But it's less than that given the nature of the structure of the arrangement.
So it's not like a one-to-one.
No.
Yes, sir.
Initially, from what I understood, it was projected that there would be about $430 million in savings over 3 years.
About what? I'm sorry.
I'm sorry, I saw that there was reported, and the original estimate was there would be about $430 million in savings over 3 years. And this is, I guess the final number came out at about $1.1 billion over 5 years.
Yeah.
The number of entities involved is about the same as the 30 originally projected. Why is the difference?
The membership numbers are higher, significantly higher than what we anticipated originally. We also had a range of estimates, and as we said, this is the up to, this number is the upper end of the range that we've had an estimate for.
Yes, there's a question right there.
Are these 30 pioneers all going to be measured against one another in terms of how they meet certain quality measures And if so, is that going to be publicly posted?
The quality measures that we used in the Pioneer program are going to be the same measures that we used in the shared savings program, which are going to be will be published and available to the public. These will be also over time. And they also will be the same metrics or similar to metrics used for other programs such as Medicare Advantage and other organizations and programs that use HEDIS measures. So there'll be a great opportunity to compare results from the pioneers to many other approaches to delivering care.
Out of this initial group, do you know how many are truly integrated systems in the sense that they employ their doctors versus the sort of fee-for-service arrangement?
Yeah, it's a wide array of folks. There's a set of folks that a little bit over half that have some component that's integrated, and then there are others that are more IPA-based or physician model-based. So it's quite an array of arrangements and networks that we have participating.
Looks like there's some questions back here. Got-
Hi, sorry, just to return to the application process. So are you suggesting that the applicants themselves, the 50 some odd who are not with us this afternoon, made the decision on their own that this was not right for them, or did HHS make a decision that they were not, that the
No,
providers were not?
there was a process through which we identified those we thought were more likely to be successful, and were further along in developing their capabilities. So there were definitely some that we felt were not ready for the Pioneer program. But there were many also who decided along the way that they wanted to do other things. Other programs came out along the way. The shared savings program was redesigned, and there were other opportunities as well that people decided they wanted to pursue. So it was some of both.
Thanks.
I'm curious, I'm really loud. I've talked to some folks looking at this and who've expressed some skepticism about the savings that could come from the ACO program. And one thing that they've pointed to is the experience in the PGPs, where not all the PGPs were able to reap the shared savings. And this may be as much a question for the participants here as for you guys, but what gives you confidence that this will work out better both for the health systems involved and Medicare than the PGP program might have?
Great question. We're happy to say there are 3 PGP groups who are in the Pioneer program. They're here today, and we hope you have a chance to talk with them afterwards, and they can give you their answer to that. I think we learned a lot through the PGP program. The model here is fundamentally different in several respects. One, there is 1 year of shared savings without any downside risk exposure for some of the plans. Others are going directly to a risk-based model, and where there's exposure if there are costs exceed the targeted budget amount. So this is fundamentally different. It is a different program from the PGP model, where there was no real penalty, if you will, for having costs be higher than they started out. So that's number one. Number two, we're asking pioneers in this instance to reach out and establish contracts with other payers so that greater than 50% of their business is now aligned with this alternative approach. And we believe that that really takes us out of a world where people may be kind of pursuing 2 business models but not really fully fledged, fully in the process of transformation, to one where these folks, the pioneers, are serious about transforming their clinical models to deliver the outcomes we're after. We think that's a very different program from PGP.
The Secretary, excuse me, battling a cold. The Secretary has an appointment at the bottom of the hour, so we want to thank her for joining us today. And Rick Gilfillan and John Blum will continue to answer questions. Thank you very much. Next question, please.
Suddenly lost interest. Okay.
Have another go at this. Some of these health systems, and I guess I would single out partners, are in some of the most costly states in the country in terms of healthcare, as a study you guys published a couple weeks ago showed. Will they earn bonuses just based on doing better than they're doing now, which is very expensive care, or will they be measured against lower cost systems in the United States?
We have a great mixture of folks in the program from high-cost states and low-cost states. And I would look at the list. You can see folks from Minneapolis, folks from Iowa, folks from Illinois, places where rural places where costs are low, and we have folks from urban areas where costs are high and suburban areas where costs are in between. They're all over the map. Everyone's program will be based on their experience. It's similar in that regard to the approach that we took with the shared savings program. Right now, they will be judged based on their ability to demonstrate improvement over the historic experience of their population. That's correct on the cost of care side. On the quality side, they'll be measured against how they're doing versus other benchmarks in the industry. So everyone's going to have to exceed the benchmarks that exist today and will be developing as we go forward to ensure that they get their full rewards by demonstrating that they can do a great job improving care and health as well as managing the cost side. Other questions? No? Okay, thank you all very much for being here today.